great futures. And I went to Bowie State to get a master's in mental health counseling, thought I was going to be a therapist, started my internship and realized that while I love mental health, therapy was not the right fit for me, and was lucky enough to be selected for a program that taught veterans how to become national advocates. And really at that time, that was when I realized that the skills that I'd learned as a parent of special needs children would serve me very well in the work that I do now. And, you know, if I'm honest, some of the skills I learned as a counterintelligence agent have come in kind of handy too. Things like lie detection and understanding body language when you're on the Hill come in kind of handy. But what I learned is I had the blessing to work on the Veterans Health Council for 3 years, one of those under Dr. Artie Shelton, who I absolutely adore. And that's where I met Janet and Nona and have learned so much from them. I am definitely a newer player to this game. I'm humbled to be here with Kathy and with Mark because they are powerhouses and I'm kind of the new mouse to the scene. But as I worked with the Veterans Health Council, what I realized is how disconnected the civilian side of healthcare is from veteran health, and how important it is that we as veteran organizations work with patient advocacy groups as well as with medical colleges and institutions to make sure that veterans are receiving their best health care. I know one experience I had that really lit the fire for me was I was having really bad chest pain, really bad, to where it felt like an elephant was sitting on my chest, and every breath I drew, that elephant wouldn't get off and was getting deeper in. So I called the nurse hotline and was told, "Oh, sweetie, it's just heartburn, roll down your window." And I was like, nope. And I went to the ER and I got my EKG and I was waiting for the doctor to come in, and he came in and he's like, "Well, your EKG looks okay, so we're just going to send you home." And I said, "Well, sir, I'm a veteran." And he kind of limply shook my hand and was like, "Well, thank you for your service." And I said, "Well, do you know that as a woman veteran, I'm 5 times more likely to die of heart disease than a civilian woman?" And he was like, "I had no idea." And I said, "Maybe we should take another look." So he did an x-ray and it turned out I had a horrible case of pneumonia. And so to me, that really brought home how important it is that we educate our civilian healthcare providers about the unique healthcare needs and risks that we have as veterans. And then, you know, even still, I work now at Paralyzed Veterans of America, and I do much more policy benefit side and a little less healthcare. But some of my connections will reach out to me and ask for, you know, who talks about cancer in the veteran space? And sadly, there aren't very many. And so it's not just a matter of getting the patient advocacy organizations to understand why we need to work with the VSOs, but getting the VSOs to understand why it's so important to work with the patient advocacy groups. Because only when we work together are we going to move this mission forward in a meaningful and impactful way. So I'm excited to be here. Thank you all.
Sure. Thank you, Maureen. And, you know, I have some slides, you know, that Kathy shared with me that I think really sort of illustrate what you were just talking about. So if you give me a technical grace, I think I should be able to pull it up. And maybe we can come back to that. But while we do that, Mark, why don't you go ahead and introduce yourself, and then after Mark goes, Maureen and Kathy, I'll sort of pull up those statistics that you guys know well and have you guys speak on those for a second.
Great, good morning. Hello, everyone. My name is Mark Gibbons. I served in the military and the Army for 10 years. You can tell I have dogs home with me right now. But I was 5 years enlisted, 5 years as an officer. I was fortunate enough to participate in Desert Shield, Desert Storm, and also in a humanitarian effort called Operation Provide Comfort. During this time, though, I have been diagnosed with a wonderful Gulf War syndrome. So I do use the VA system. I go twice a year for testing. But I have always tried to keep involved in the military one way or the other. Luckily, through this job that I'm currently at, and my old job as well, I've been able to deal with the veterans and their family caregivers. Last summer, we were fortunate enough, thanks to a sponsor, to go do a survey in Iowa at the Iowa State Fair. And I was surprised to see so many dual eligible seniors out there that not only have Medicare, but also are VA. And so, but after I started investigating more, we realized that the overlooked population was the women veterans. And we need to try to figure out some way to do more for them. And I think as we get along this morning, we will talk more about it. But again, that's just my story in a nutshell. But I'm honored to be here with these wonderful other panelists. Thank you.
Thank you. So Mark, you sort of, nicely teed up what I was trying to come back to. So let me pull up these slides. And, I think as I pull them up, when we spoke last week, you guys sort of reminded me that, one might think that, all veterans are getting their care, at DOD, or at VA hospitals, but that's not the case. And Maureen, I think your story there sort of illustrates the importance of making sure that we're all sort of aware, of these issues, and that, we work with, providers to make sure that they have, sort of the awareness and understanding to make sure that all veterans, and especially women veterans, get the care that they need. So I'll just sort of go through these slides, but, if you all have any additional thoughts or sort of reactions, to what's here, please share those.
Well, look right there on that slide, the mental health challenges among women who have served versus civilian women. I mean, just look at each one of those there, but the suicidal thoughts in particular, and depression and any mental illness in the past year, the bottom there, those are significant differences.
Yeah, and to build on that, Kathy, when we talk about mental health among service members, everyone tends to think of PTSD. That's immediately the mental health disorder that's most commonly associated, but actually it's depression. About 30% of veterans leaving military service have depression. And, if our healthcare providers aren't screening for it, if you go back to the first slide, you don't have to, but the first slide said, that veterans almost tend to report higher that they're good or very good in their health. And yet when you look at these other slides that you're going to show, you're going to see, while we might say we're very good, when you dig down deeper, you see that we actually face some pretty significant health challenges and disparities. And so it's really important to have more than just that surface level thank you for your service conversation with veterans when it comes to our health care.
And you're exactly right, ladies, that what the good thing is that what people don't realize if you're not in the military circle is that a lot of the veterans that are actually getting help with the mental health issues are getting it outside of the actual VA hospital proper. And they're going to have to go to a lot of their clinics because in some cases, I guess in most cases, they're not easily accessible to the VA hospital. If you live in, let's say, I don't know, in Midland, Texas, your closest VA hospital may not be Dallas. So you're gonna have to rely on some of these other type of clinics and services. And so, but I wanted to say something real quick. We were talking to some veterans, and I had my staff put some questions out. A lot of the veterans are very pleased with the VA system when they can get in. So I know we hear horror stories about these long waits, and there are long waits, but the quality of care that they are getting when they do get in there is just phenomenal.
Mm-hmm. Oh, I agree, Mark, 100%. Getting back to, the women veterans and them seeking care in places other than, just the VA. We've tried to look at this in many different ways and to find out why that is. And of course, you understand that many women veterans, don't identify with even being a veteran themselves, or don't want to identify for whatever reason, or don't feel comfortable or welcomed going into a VA facility itself for whatever reason. And I know the VA's been targeting those efforts and trying to make it more appealing for women. I know here at the Washington, D.C. VA, they set up a beautiful new women's health clinic where you can get breast cancer screening and all those, women's health kind of things. But I know that's been something that the VA has been concentrating on. And as all of us know, women are the fastest growing segment within the military, and then hence the veteran ranks themselves. So there will be more needs for women's health services. And one other thing that distinguishes the VA from civilian sector care and even TRICARE in the military, VA doesn't take care of the whole family. And we know women, of course, have their, by and large, have their children and things. And for them not to get that care there puts up kind of maybe a false barrier, but a potential barrier nonetheless. I don't know, Maureen, Mark, you guys may have some thoughts on that one.
Sure. I can attest to that as a military spouse. We've just moved here to Virginia after moving from California, from Maryland, from Arizona to North Carolina, Washington State, and Germany. My healthcare records are completely disjointed. Every time I go, I have to reestablish everything with my healthcare provider. And just to get into this clinic here where I'm now being seen, I had to fill out 15 different I don't even know what the form is called, but the permission for my records to be shared. And so, for someone with a complex healthcare like me, a disabled veteran, it makes the continuity of care very, very difficult. And given how much we move, having children with special needs, we move somewhere, they go to the bottom of the wait list for these services. And by the time they're finally in treatment and starting to see progress, it's time to move. And guess what? We're back at the bottom of the wait list. And it makes that continuity of care very frustrating. I think also to your point, Kathy, just to give you some numbers, the assumption of the general public is all veterans get their health care at the VA, and really only about a third use the VA for any and all health care. And a smaller percentage, about 16%, are using the VA for all of their health care, which means that the majority of veterans are out in the community getting their health care. And so part of the problem that creates, similar to the military spouse, military child issue, is these darn records. And when you go out in the community for care and getting that continuity of care and making sure those records get back into the VA, if you are someone who sees the VA. But for someone like me, I don't use the VA at all because my husband's in the military. So I just use TRICARE. The research shows that, like Kathy and Mark have said, veterans do better when they're getting their care in the VA because you get comprehensive veteran-centric whole health care. And what I get as a TRICARE recipient is kind of whatever I push my provider into giving me. And so, we want to make sure that every veteran and every family member has the opportunity to thrive. And we need, the help of patient advocacy groups that you all represent to make sure that that's happening.
Well, Maureen, your point about, a lot of people who might be duly eligible with veteran status and TRICARE status. I'm one of those myself as a military retiree. So you almost have to choose one or the other. And I think Nona wanted us to bring this up too, for those on the call here. There's distinct, how military people and their families and veterans get their health care can be a hybrid approach of, as a result of two main systems. You have the DoD, the Department of Defense, which administers healthcare through the direct care system, the base hospitals, and the TRICARE health plan, which is the contracted insurance networks of care, the civilian care. That is for military people and their families under the TRICARE program, and military retirees. The veterans get their care through the VA system, which is another bureaucratic organizational structure in our government, a very big one that has a network of, VA bricks and mortar hospitals, and they contract for care out in the civilian sector as well if they can't provide it for the veteran. The veteran, I use myself as an example, and you, Maureen and Mark too, have service-connected illnesses or things that were deemed, resulted from your service, kind of a thing. And those are determined by percentage points and things for specific illnesses. I have one for, certain percent for hearing, for instance. So I can go to the VA and get those hearing services, but I'm not authorized, or I actually can go if I want to pay for it, get other general health services that I'm not service connected for at the VA. However, I don't choose to do that. I get it in the TRICARE system. So that's where all my records are electronically. But it just goes to show, to underscore Maureen's point, that when you're going in the civilian sector to get care for some of these things, and they're the result of a service-connected issue, which, you know, let's face it, our bodies, our systems are all connected. So you can't just isolate one thing from another. You know, the cardiovascular system is connected to everything, for instance. But so it's awful hard. And then to get people to understand where those things would cross the civilian providers is very difficult, because they are not, as Maureen has said, they are not thinking about your service-connected illnesses being part of your service, kind of a thing, until you bring it up to them. And, you know, you may or may not bring it up to them. I mean, I don't always think about it when I'm going to get treated for something. So it's very difficult. So I think that challenge of creating an awareness in civilian providers and civilians in general regarding, you know, the impact of service and sacrifice, you know, that our veterans have. So that's my soapbox. I'm going to get off it for a little while now.
No, you're exactly right, Kathy. And I think we have to train the medical world outside of the military that not only it's common for someone to see a male. If Artie were to walk into or Thayer were to walk into just a doctor, oh, they're going to say, oh, were you a veteran? But they don't ask Maureen or you right off the bat, oh, were you a veteran? For some reason, that just isn't clicking.
Right.
And we have to figure out how we should help educate the medical world to ask those questions of everyone. Because like you said earlier, the numbers are rising heavier towards the women veterans that are out there. And that's just true around the world for around everything. But we need to learn how to change the actual mentality. Because just like, you know, you were talking about it in regards to you were having heart problems, but no one ever asked you, did you serve? I mean, you could have had some complications because of you were exposed to pit fires or oil fires or who knows what. But no one never thought to ask you, because what would you be doing in combat? That's not right.
You know,
Yeah.
one other thing I was thinking about, especially Maureen reminds me of this with her children and her exceptional family member, EFMP, probably children. That, you know, that the children, when they go in for healthcare needs and things out in the civilian sector, whether it's their school shots or you know, whatever, immunizations or broken bones or whatever, you know, that we have found that children have, from our newest generation of service members, really have been traumatized in ways we're only beginning to understand. And so I don't know that the children are assessed. You know, talk about women veterans. What about our children?
You're right. What I'm concerned about is like earlier, before this whole started and when it was online, Maureen was sharing with us that her husband's going to retire. So what happens now with the children's records as they leave and you have to transition? You have to start all over again. It's bad enough when you have to PCS or move. I'm sorry, when you change your station, you permanently change your station, and you have to kind of start over. But now, how do you transition from the military, and you transition your whole family now into to this new world? Now you're gonna have to figure out, you know, what do I have to do again? Hopefully you've already established and you can keep the positions that you have, but what if you can't? You know, and so what does the military family do then?
Well, you know, that's one, you know, this is still, you know, still coming very slowly, but the electronic health record that the VA and the DoD have adopted, it's, you know, they're using the same platform and the same company to develop these things. So it's going to be, you know, the goal and objective is for it to be one, for the service member and veteran to have one longitudinal health record from the day they raise their hand to, you know, all through their veteran status, you know, all through their life. So that is the goal of that. So, and ultimately the civilian providers, you know, especially if they're contracted with the VA or TRICARE, will have access to that too. So people, you won't have to start, you know, collecting those private, you know, making copies of things to bring over to the military hospital or the VA to hope it gets in your record.
Right.
That's a little far off, you know, I think a couple years.
it's definitely a work in progress. And like I said, a big part of it that I have yet to see a whole lot of plans for is how to incorporate those visits out in the community, coming back to, and what about those veterans who aren't using the VA healthcare system at all? But I want to talk to a point that Mark and Kathy have also touched on, and that is awareness of civilian healthcare providers. My last year at the Veterans Health Council, my partner, Rebecca Patterson, and I traveled across the country going to conferences of physician assistants, family therapists, anesthesiologists, all of these different medical services. And we were actually using something that Kim Zubrek is quite familiar with, the Have You Ever Served pamphlet, having that discussion with these young students. Do you ask any of your clients if they're veterans? And they're like, oh, no, I don't see any veterans. And my response to them is always, are you sure? Are you asking? Because the research shows that 1 out of every 7 patients they see is going to be a veteran. And so if they aren't even trained to ask that question, God only knows what they're doing, what they might be overlooking. As a younger woman veteran, my risk for breast cancer is higher than my civilian counterparts. And yet not only do I have the higher risk of breast cancer, I have a higher risk of it being much more aggressive. So if I'm not being screened, then my risk of it getting much worse or going to a higher stage before it can be caught is pretty severe. Same thing goes for like Vietnam veterans and prostate cancer. They put out recent recommendations that men over the age of 70 don't need to be screened anymore unless they have specific health risks. And yet Agent Orange exposure was not one of those. And we know that Vietnam veterans with Agent Orange exposures are not only more likely to get it after the age of 70, but when they get it, it's very aggressive. And so providers should absolutely be asking that question and screening, and yet they aren't. And another point that Mark talked about, I want to touch on, is wait times, right? We hear abysmal things when it comes to wait times for VA appointments, but the research has just come out and shown that wait times in the community aren't any better. This is the provider shortage is the issue that not just affects veterans, it's affecting everyone in America. But, we hear about how awful wait times are at the VA, but they're actually putting a lot of efforts in place to make it better. And yet when we send veterans into the community for that care, and there are no requirements right now for those healthcare providers to know anything about veterans, we're just sending them out there and paying for it. They're still waiting just as long, if not longer. So we really have to pay attention to how our veterans are being treated in the community, even if they're going through VA care.
Yeah, I agree with you, Maureen. One thing this COVID crisis has done, I think it has really exposed our nation's healthcare system and what some of those, are shortages of providers and resources, particularly in more rural areas. And, more rural areas, that's where a lot of our veterans are. Our healthcare workforce needs to really be bolstered, and hopefully that's being addressed with the new administration and part of some of their planning. But I think we need to really look at that hard.
Kathy, and you're correct. I mean, our veterans that are in the rural areas, my uncle ended up getting COVID, and he lived in Beeville, Texas. Mm-hmm. Well, the closest VA hospital was San Antonio. Well, I'm sorry, San Antonio for those. I'm from Texas, so I just say San Antonio. But so they took him to the hospital there in Beeville, which is a good hospital. But they realized that the care that he needed, they had to transport him to BAMC in San Antonio, because the VA hospital in that area, Audie Murphy, was completely full. So they took him straight to BAMC. Well, I mean, it took a long time for them to get the paperwork and everything else. He ended up passing away from COVID several days later. But I mean, we have to worry about, make sure that paperwork and the wait times and all those things. So it is something that we have to worry about. And like you said, Kathy, a lot of our veterans do live in rural America. And how do we get them the care that they need, even if it's with a clinic? How do we make sure that they're getting the coverage that they need? And also, do they know that they're able to do that? So it's also educating the veteran themselves. And we need to do a better job on that as well. Maybe they just think the ones that only have VA, that they can only go to a VA. Well, that's not true. They have made stipulations that, if within a certain mile radius, if you're not within that radius, you are allowed to go to other. So, but I don't know if everybody knows that.
So Mark, hi, it's Michele Oshman here from Bio. Thank you so much for being here, all of you. I'm wondering, since we have the audience right now of a number of patient advocacy organizations, and certainly, again, I echo what's been in the chat and other folks have shared. Thank you so much for your service, first and foremost. My father was a veteran, and I just have the greatest respect for all of you. I wonder if, are there ways or are there models that any of you or maybe any of the patient advocates on the line have developed to to be able to do that sort of cross-pollinating, for lack of a better term? I think Maureen mentioned earlier, how do we work together with the patient community? Having worked with the ALS Association a number of years ago, I remember they did have a connection into the military because of the comorbidity, but I wonder, are there other disease areas? And if not, can we help you connect with those organizations?
That's a good observation and good question. I know I can speak for the Military Coalition, which I co-chaired the healthcare committee in that, and we had many different entities that came to us to partner with our respective organizations on different health initiatives. Lung cancer was one, in particular, for veterans because of toxic exposures and things, the increased incidence of lung cancer. That was one disease patient advocacy group that we worked with, and we worked to get the coverage of both the VA and TRICARE to cover spiral CTs for people that were being discharged so they could screen for lung cancer. That was an example. And the Arthritis Foundation is another one, because we know musculoskeletal injuries, when you're young, when you go in, you jump out of planes and do all these things. Well, you pound your body, you injure yourself, through years of that kind of stuff and more. And it comes home to roost, when you get a little older, and then here you find yourself discharged and you have all these arthritic joints and things. So, we're trying to do some research into the etiology of some of those injuries and what that will do later in life. And if we could have DoD develop protective equipment to help with preventing those kinds of injuries at the front end, so the VA is not having to take care of things at the back end. But there's always new things. There's new toxic exposures being identified all the time for our service people. So it's something you got to keep tabs on.
Yeah, and Michele, thanks for asking that question. I know for my organization, Retire Safe, I have to do a better job of partnering with other organizations, especially the veterans groups, so I can figure out how to help educate my membership. I know I do have a lot of veterans that are members, but I need to figure out what information do they really and truly need to help them navigate as they are retired and make sure that they're getting the quality of care. I know Artie's group, when I would sit on the Vietnam Veterans Council meetings, I always left there with so much information that I was able to share with my membership. And it's things like that I need to do more actively and share more information. It's just about getting the word out to my folks, and I just need to do a better job of that.
So we have a comment question in the chat, and I don't know, Karen Marshall, who is with the National Alliance for Caregiving. I don't know, Karen, if you want to share your question, or if you'd prefer that I share it.
Sure. Thank you, Michele.
Yeah, go ahead.
So, good morning, everyone. And again, thank you so much for your service and for all of the insights that you've shared this morning. So I'm asking my question from the perspective of a former family caregiver. As I mentioned in the chat, I was a caregiver for my father, who was a Korean War veteran who lived in a rural area. And towards the end of his life, he made the decision to start getting a lot of his care, all of his care, in the VA system. And this was a few years ago, pre-Mission Act expansion. And I know that I wasn't necessarily prepared to support my father as a caregiver in the VA system, simply because as a family, we just hadn't received any services from the VA system, and I was just unfamiliar. And quite frankly, very overwhelmed with my caregiving duties to sort of become proficient in navigating that system when I had barely mastered navigating the civilian system for my father. So my question is, what's the biggest piece of advice that you would have for today's family caregivers who may be helping their families now that they've heard about the Mission Act expansion and the potential eligibility of their loved ones who were pre-9/11 veterans to receive care in the VA system? What's your biggest piece of advice for them in assisting their loved ones who are transitioning their care to VA?
Hi, Karen. I think I wrote, I would first start with what I think is a premier organization that supports military and veteran caregivers, the Elizabeth Dole Foundation. They have counselors, they have an enormous amount of clout and understanding with regarding benefits for every era of veteran who requires, family who requires caregiving. That would be where I would start.
No, you're exactly right, Kathy. I was going to say the same organization. They have a network and all these different Facebook groups that are private groups, but they will bring you in depending on where you live. But they are so well connected, and they have training materials, and they've also benefit off of the VA family caregiver training program that they created. That was for post 9/11, but they've expanded it. And so there are tools out there. But I would definitely contact the Elizabeth Dole Foundation. The best advice I can tell you is that the best information you're going to get is from a peer, because at least they are walking on the same path. It may not be the exact path that you're on, because every family caregiver journey is different one way or the other. But at least they'll be able to share with you the struggles they've had, the victories they've had, and it would maybe help you save time. So definitely reach out to them. There's other organizations that are out there, such as I forgot what it's called now, but I'll think of it. I'll type it. But there are other organizations that can help you get the information that's needed.
Too, I agree. The Elizabeth Dole Foundation is a wonderful resource, but also if we're talking specifically caretakers of veterans using the VA healthcare system, I would suggest getting a very up close and personal relationship with the VA facilities patient advocate, because that's where you're going to be able to communicate what's going right, what's going wrong, and take action to rectify what's going on. I think sometimes caregivers who aren't veterans that are dealing with the VA system might be a bit intimidated by it, or just don't know how those channels work, and may not even know there is a patient advocate, but they are there and they're there to help. So that would be my best advice to someone who's taking on caregiving for a veteran in the VA system.
Thank you so much. This is wonderful advice for our grassroots network. Thank you.
Yeah, thank
If I
you.
could too, I would love to touch back on Michelle's question about how patient advocacy groups and veteran orgs can work together. And I think my first piece of advice would be have a conversation, reach out and talk to us, because there are lots of ways that we can support and align one another, but we don't know that until we have that conversation. I know when I was at the Veterans Health Council, we would do things like help create materials to educate our veterans with information that patient advocacy groups would bring to us, but we gave it a very veteran-centric lens. There's also a lot of intersectionality between patient advocacy groups, especially because veterans have a lot of comorbid conditions. So you could be a veteran with arthritis, cancer, and be a person with a disability. And so there's groups that can all work together to better inform even, the intersectionality of race, socioeconomic status, LGBTQ status, all of those things, the interplay of those is very important. And so just reaching out and starting those conversations and learning where you might be able to align your forces. And then also when you're having panels or when you're discussing strategies, try to ensure that someone who is either a veteran or very well familiar, like Nona or Janet or Kim, with the veteran community is at the table to be a part of that conversation, can really make a difference in your efforts.
Thanks, Maureen. And, I think building on that, Mark, thinking of your organization, what are some things that you're working on or have worked on in the past that you think might be, really impactful, for not only your community, but veterans, at large?
Yeah, so what we'll be working on this next year is, again, we're going to be turning our focus on women veterans, women who have served, because as you can hear through this conversation, they are the actual underserved, but they are one of the largest populations. And so I need to figure out how many I have, what their needs are, what conditions they're dealing with, what are their struggles, what are their victories that they're having, what quality service are they already receiving, so we can continue that, and what kind of recommendations we can give to the VA system. And it would be working with like with Kathy and others, another organization, so we can come up with a good solution, or at least identify targets that we're concerned about or that our members are concerned about, to help them navigate this VA system, or TRICARE if they're a retiree, or whatever it may be. But we need to better understand what the needs are. We have to do a better job of listening, not just telling or communicating, but we have to listen to what they really want and need.
Sure. And just in case folks haven't been watching the chat, Michelle, put in a good question, sort of for the audience, do your organizations already have, military or veteran support programs, or do you sort of, maybe in listening to this conversation, have any ideas? And I guess for our panelists, I'm guessing you all might have some thoughts, maybe for us to sort of discuss here. So if anyone else or our panelists has any ideas, feel free to jump in, or of course, place it in the chat. But just wanted to make sure that folks saw that question that we posed. I think too, another thing, I think I mentioned this, sort of at the beginning, is just sort of general awareness, right? I think when we, led off, I talked about how much I had learned, after sort of Nona, introducing us. So, I can sort of realize, where, I sort of had a lack of awareness here. So I know that this conversation has been so, sort of educational for me, and I hope that it has been for others. But as we sort of come, to the end here, I think, what are maybe, just a few sort of key points, things that you would want, folks like me to take away, that don't have, sort of the military experience, or don't interact with veterans very often? What are things that you would want people to know and sort of carry forward with them?
I think I'll just jump in. I think what I'd want people to know is that even though the military veteran population as a proportion of people in our country is very small, kind of less than 1% have served or are serving, that understand these people who step up and do this, really our nation owes a profound debt of gratitude to them, and to celebrate their lives and their experiences at any opportunity, not just the Veterans Days of each year, but just, when you come into contact with them or seek them out, they just, they're, most of us won't, walk around proclaiming it, but, they're just, the impact on our nation from this population has been profound. So, and their families, I should add.
Yes, thanks.
I think a key point I would remind everyone to take away is veteran is only a piece of my identity. I'm a mom, I'm a policy wonk, I'm a daughter, I'm a sister, I have a disability, I live with arthritis. Like, it's just a piece of who I am. And I think my best advice would be, if you really want to incorporate veterans into your strategies or into your efforts, have a conversation, listen to us. Let us share our truths with you. We'll listen to you. And that's where we can really start building something that will really be comprehensive and helpful. I think also understanding there are so many differences, within that, what veteran means to someone personally. Like Kathy said, a lot of women don't identify, especially women who served kind of in the Vietnam, World War II area, are much less likely to identify as veterans. And they do that for a number of reasons, but Vietnam veterans came back to a country that spit on them and threw garbage at them and criticized them very heavily. They were not welcomed back at all. And they and other veterans worked very hard so that veterans like me, we come home and we're thanked for our service. So what that veteran identity means to me is very different to what it means to someone else. A woman or a man who has been through military sexual trauma, that veteran status might not be something they're proud of, but it is a piece of their identity. And so by having those conversations, we're really going to understand better how to serve the patients we're advocating for.
Yes. Hello, Amanda.
Yes, go ahead.
Yes, hi, this is Artie Shelton. This is my first time, being part of this. And let me just say that I'm the director for Veterans Health Council for Vietnam Veterans of America. And so I want you to know that, I'd like to be further participate, but this is really a very worthwhile, advocacy group that we're doing. I want to first also thank Maureen. Maureen was my deputy and my mental health expert. And she taught me a lot. She introduced me to Nona and to Janet, which was very, very helpful. And we have not been able to replace her yet since she left. So I'm at the clone her. And just briefly, she was talking about, how the Vietnam veterans were not given the respect, having served. I served as a medical task force commander in Mogadishu, Somalia, and took 180 men and women into combat. And we, 6-month deployment, we only lasted 4 months before we developed PTSD. And because of Black Hawk Down, we were not given the, the respect, that, just like the Vietnam veterans, when they came back, and it created a lot of depression, and other health issues, for us. So we're a strong advocate. And one of the things that what we're trying to do is in Veteran Health Council, we have to educate our healthcare providers. And so we're working with the Association of American Medical Colleges to really get information to them of how to treat veterans. And so what we're trying to do is within the medical school, starting there to educate the young doctors, about the future of taking care of our veterans, among other things. So I'd like to work further with you in the group and see what we can do to promote this.
Thank you, Mr. Shelton, for sharing that. And, I think it sounds like, this has been a wonderful conversation, but it sounds like, that maybe bio can sort of play a role in bringing, the folks that are, on this call today and others together again to really, dive into these issues and, discuss ways to, partner and make sure that, we're all working towards the goal of making sure that everyone, but especially veterans, have the access to care that they need. So glad to hear that, you're sort of excited, to jump into that work. So we can sort of, Michelle and I, take that back and think about how best to, execute on that moving forward. So thank you again for your comments.
Thank you.
Yeah. Mark, I think
Amanda.
Oh, go ahead,
sorry.
Janice.
No, I was just going to say, I literally just got an email saying that Dr. Shelton actually just posted a blog on NFID's website about veterans' health care and the importance of keeping up their vaccines, and particularly in this time of COVID. So maybe we could shoot that link around to everybody so that it can get broadly spread.
Sure,
I'm not competent enough to cut and paste it and get it in the chat, so sorry. Otherwise, I would do that for you.
No, it's okay. You guys know that we usually send out sort of a quick sort of wrap-up email after this, so I'm happy to include that and the other things that I've jotted down here this morning as well. And, I guess building on, if there's other things, I saw folks in the chat, it's hard for me to sort of watch the chat and also like watch myself on screen and make sure that I'm unmuting and muting everyone. So I know folks put, I think maybe 1 or 2 other things in the chat. So I'll make sure to grab those as well and share those with the broader group in my email in case I missed it in our kind of popular chat this morning.
Good.
Mark, I think we were sort of going down the line, and I think we might have not given you a chance, so I don't want to leave you out before we close out.
Yeah, no, the main thing I want people to just remember is that all these things, all these benefits that are freedom of speech, all these things that we enjoy, are all because people decided to fight for these rights. and some of them gave the ultimate sacrifice. Like I forgot which, I don't know if it was Kathy or who it was that said, but 1 in 7 is a veteran. There's veterans everywhere. So just remember that when you're walking around and reflecting about like today, and just realize that one of your coworkers might be a veteran. You just don't know it, because it's not something that we go and we walk around and say we're a veteran. We don't do that. That's just not the way that we are wired. We just serve because to us it's the right thing to do, and given the opportunity, we would do it again. So just remember that, and we're just thankful that we have our freedoms, and I'll just leave it at that.
Oh gosh, well, thank you all so much. This has been just such a great time, to spend this morning on a day, like today. So thank you again for being here and for, your being candid and sharing your story so passionately, and, being willing to teach us all, new things and new ways to partner with those in the advocacy community. I thanks everyone for joining this morning on what is a rainy sort of Wednesday morning here. We will be back. We'll take a break next week, but we'll be back the following week with a new exciting topic. Michele, I don't know if you have any sort of closing comments before we close things out, so I'll turn it over to you.
Sure. I don't know if you have you already shared the slide I shared with you.
Sorry, but let me
don't worry about it. So there, we do have 2 additions to our team, both of whom arrived on November 4th within hours of each other. So we're going to show a picture now. Ashley and Barrett both had their babies on the 4th at the same hospital. And Barrett's baby, her name is Blake Jean Brannaman, and Ashley, her daughter's name is Abigail Louise John. So, and if we can't get it here, we'll share it. Oh, here we go. Just very sweet little girls. So our team has doubled in size, and we just wish them the very, very best. And
It's awesome.
With that, again, thank you for joining us today. Thank you so much again for your service, your willingness to share, and your leadership. And to, I think Amanda had a great point there, a great idea for us to get together in less of a presentation format, but maybe a brainstorming exercise to just, and network, connect to each other so we can learn from the great work that that all of your organizations are doing. So thank you very much. Thank you.
Thank you.
Thank you. Have a good day.
Thank you.
Take care.
Everybody be
Bye.
safe. Bye-bye.
You too.